Great, thank you very much, and also very much appreciate the kind invitation to join you all for this session. I've been at other NIA meetings on antibiotics, and I will say with real compliments to NIA, this is a group that has probably done more, I think, to progress the conversation and dialogue forward over those 7 years than anybody else. So my compliments. And so what I'm going to talk about is, I think what's on a lot of people's mind and has been probably for a couple of years at this meeting. What is it that we can do, should do, and when we walk out of here? So I'm going to give you a scenario that I'm going to talk about. And I think when we're done with this, what I would hope to accomplish would be an outcome that between NIA number 7 and NIA number 8, we will enter a new era of action. That we will actually be taking major steps into transferring knowledge into action, and that will be the transformation from meeting 7 to meeting 8. So here's the scenario, and I should have really had you do this last night as I thought about it. So you're going to wake up tomorrow morning, and you're going to all of a sudden have a pool of money, and not a lot, right? We're in agriculture, but a pool of money, maybe $10 million, something like that, let's say. And you need to focus that $10 million on optimizing human and animal health with a focus through antibiotics. And when you come up with your decision, I want you to say, well, what actions can I take next? Here's my money. And the criteria is it's got to be cost conscious, I would say cheap, but relatively speaking. It has to have the greatest impact, do the most good. You has to be started right away between our sessions, and there has to be proof of effectiveness. So if I would have you take out a piece of paper now and write those things down, what would they be? So when you get some quiet time and not tweeting, why don't you think about actually doing that? So I'm going to give you my 2 cents of what that scenario looks like. So that's what I'm going to do today. So we know that AMR is really a complex problem, and I like this quote from John Muir, who's a naturalist, who said, when one tugs on a single thing in nature, he or she finds that it's attached to the rest of the world. Well, that makes it pretty complicated. But that is the One Health kinds of activities that we find in what we're learning about the environment and the interactions across all of our microbes and all of these species, right? And so this looks like the plumbing of the Hyatt Hotel. So this is the complication that we deal with, right? These transmissions are horizontal and vertical. They're cross species or within species. They're in our environment, they're in our food, they're in our water, they're in our hospitals, they're in our animals, right? And so the real hard thing is how do we get our arms around this? And I think that's always been the difficult thing. So H.L. Mencken was a real kind of, he was the editor of the Baltimore Sun. He was a real crusty guy, but a really smart guy. And one of his famous quotes was, for every complex problem, there's an answer. It's clear, simple, and it's wrong. And I think when we get into these really complicated problems, that's often the case. And we get disillusioned because it's not easy, it's hard to, and we go on from one meeting to the next. But I'm here to tell you that I think taking the right steps and taking the right bites to move ahead is really important. So why it's important to do this now? I'll be frank with you, I'm really worried about the loss of momentum. Okay? There are a lot of things going on in the world right now and circumstances that can easily overtake this as an issue. This is a slow-burning crisis of several decades, right? It's not a major infectious disease acute outbreak. And so it can be pushed to the sidelines. So you get a burst of momentum. I'm worried that we're going to lose that if we don't start acting right now. And the other is paralysis by analysis, right? So over the last several decades, there's been 200,000 articles that have been written on this topic. 200,000. So I would submit to you, I think we know enough to move ahead. And we don't need 2001 scientific article to move ahead. And I'm very much pro-research, by the way. The budget climate into the future is uncertain, but I'm not sure it's going to be conducive to do the things that we want to do. Another reason that there's a sense of urgency, this idea of building a coalition around the foundation of One Health. We've already talked about in other NIAA sessions the importance of that. And I always like this truism, right? When it's said that when all is said and done, much more gets said than done. So now we need to focus on what is it that we actually can do. And I also like the idea, I believe in it, the idea that culture will eat strategy for lunch. So if you don't embed these changes in how people work and in the culture, you won't sustain it. So we need to think about that as we move forward, right? So this was just a summary that came out of PCAST, the President's Council on Advisors of Science and Technology, which, by the way, hasn't been reappointed. But this was their idea of the summary of critical activities of getting your arms around, antimicrobial resistance and what to do. So 8 big things: effective coordination globally, shared federal leadership or strong federal leadership, which I don't think has been done, effective surveillance, improving stewardship, economic incentives, new antibiotics, fundamental research, and appropriate use of antibiotics, including agriculture. So those are the ways that this group saw forward of what they needed to do. And then from that became a federal task force on CARB, combating antimicrobial resistant bacteria, the PACCAR, the President's Advisory Council, and we were off and running. And these were the 5 things that really pretty much connected to the original PCAST report of what needs to be done: stewardship, surveillance, finding new ways of diagnostic tests, accelerating research, and improving this capacity. So for me, there's a lot of really good news, right? And over the last couple of years, kind of thinking back where we were in this conversation with this group a couple of years ago, look what's happened. A lot more global attention. The G20 was talking about that. The United Nations talked about a One Health strategy to move forward. World Health Organization says all these countries need to have plans in the individual countries to get ready this year to start to implement. There's been, I think, a really positive response in terms of actions taken to the FDA guidance. There's been a One Health emphasis that we agree on, improved dialogue, so the voices and the tenor of the conversation is very different than what it was a few years ago. A national strategy, the commodity group response, I'm very complimentary. CARB-X is a new strategy of $455 million coming together on a public-private enterprise. And part of it was NIH, part of it was BARDA, and some private money to come in to talk about changing the strategy, if you will, of pull incentives for new antibiotics and new diagnostics. We learn from each other, global plans, and I think the veterinary feed directive and the relationship between veterinarians and clients are a positive thing. And I know that there's some negative things as we learn to go through it, but overall I think it's very positive in this PACCAR. So my answer for your scenario is, what is it that we can do right away, right? So I put strategies into 3 tiers. Okay, this is my bias. We should have tried yours, but it'll be interesting to see if you agree or disagree. And the first tier are activities that meet criteria that I'm going to give you and can be delivered immediately or in the short term, the next 6 months. Okay? So if I'd go around, I'd probably get some different ideas, but that's what I want you to answer. The second tier are critical needs and activities that can be delivered more midterm, 1 year to 3 years. And then the final tier, also very important activities, right, but delivered on a longer-term basis, 3 to 5 years. So these tiers are not to say that one group of activities is more important than the other. That's not what I'm saying, right? But I want you to focus on the ideas of what we can do right now and in the next 6 months. Because it's really important not to lose a sense of urgency and where we're headed, and actions really speak loud. So that's what we need to do. So here's my criteria that we need to use to prioritize your ideas, right? The number of animals involved, it has to have really significant impact. Right? Tens of thousands of animals or more, or people, right? It has to also take into consideration cost. I gave you some money, but it's not a lot of money. So how are you most cost effectively, where are you going to get a return on investment? It's not 100 or 300 billion or $1 million, right? It's less, but it probably is something that's actually doable. Are your actions feasible and practical? And what is the evidence base for this? And how acceptable will these actions be? And can barriers be overcome? Okay. Is it implementable and scalable? Does it really take into consideration the One Health ideas? But it needs to be accomplished quickly. And they may be things that are already happening, but we need to accelerate them and really focus on usable results. Okay? So here's my tier. 5 activities that can be taken right now or the next 6 months. Okay? Number 1, stewardship. Well, I thought it was pretty good to put that on top since that's what we're talking about in this meeting. But it's absolutely true. So if you go back to the criteria, can this be done quickly? What are the key elements? And can we actually use this rather than a whole separate program to build on what we already know as very successful quality assurance programs and food safety programs, rather than make it different? So I think stewardship is a real key, and I think you can do it in a cost-effective way. We'll talk a little bit more about that. The second one is increasing awareness, education, and communication. So we had a really good conversation yesterday, and I really learned a lot, and I appreciate it. But we really need so if I would talk to you and say, who is the national leader in this effort? So, who is it? Who do we turn to? Where does that conversation come from? We're doing model curriculum in veterinary schools and medical colleges. But this issue has to be relevant to people personally. So I'm on the PACCAR, the President's Advisory Council, with some other colleagues here. And we start every meeting with a patient advocate who comes in and talks about why his or her future and life has been changed for the rest of their life because of an infection. And that will ground you pretty quickly in terms of what is it that we're trying to do. So I think we're not emotional enough, and we haven't put a public face on our communications. We'll talk a little bit more about that. Infection prevention. Good grief, you guys are doing that already. I've always done that in veterinary medicine. That's how I learned. It's population medicine. It's preventive medicine. We know how to do a lot of that. We haven't tracked it and actually put a number on it, which we need to do. But it's something that's already being done, that can be accelerated, and I think kind of made specific for different animal species. The last 2. What can we do in the next 6 months? Create a National Institute for Innovation Policy and Research. Okay? Well, that will take a long time. Not true. There is enough support to actually do this. So you have a National Institutes of Health that are getting, $40 billion? Do we have a National Institute of Agriculture Health? Do we have a sector that is really devoted to this strategy? And why don't we do that? Why don't we make this a big thing and really have people look at this and a focus, if you will, of moving ahead? And I don't care if it's in an agency or at a university or a 501c3 or what. That doesn't really concern me as much as what are we going to do and why that is so important to get done. And you don't need to get $100 million to do it. You can start it. Getting to first is really important. And then you build it from there. And the last one might surprise you, but it's changing the business model. And while this is probably more of an interest to the human health side and the pharmaceutical side, I think it trickles down and also impacts us. And while it takes 10 years to get a drug through the R&D and approval system, the decision to change the business model can be done right away. Well, in the near term. And I think that's really important because right now the market failures really indicate that companies will not go forward with new drugs. And what are we saying? We want you to have new antibiotics. Oh, but at the same time, we're really going to hone in on stewardship. And we're not going to use them as much. Well, guess what? It doesn't quite make sense. So what is the new strategy, I think? And people talk about a delinking model. So you separate the use of that drug and the payment that you get. And there are innovative ways to doing that. So those are the 5 strategies that I think fit the criteria. So it would be interesting to think, and I'll give you tiers 2s and 3s, but let's talk about this a little bit. So stewardship, commitment, and there's different definitions, and my concern is we're going to get wrapped around the axle on definitions and wordsmithing. There's some key elements to stewardship, and you can do it across all species. Commitment to always use antibiotics only when necessary to prevent or treat disease. Choose the right antibiotic, administer them the right dose, the right period of time, the right route of administration in every case. And the outcome, optimizing clinical outcomes, whether they're in humans or animals, minimizing unintended consequences such as toxicity, selection of pathogens, and the emergence of resistance. And there's a lot of evidence that stewardship, when put in place and sustained, will actually show a reduction in both use of antibiotics and in resistance. So we don't have to prove the evidence that that's the case. We just have to do about the implementation. So here are CDC's core elements of hospital stewardship. So I'm not selling these, but I think we don't need to start from scratch. There's a lot of these that are pertinent to what we would do in animal agriculture across species, right? So let's not get wrapped around the axle in terms of terms. There are elements that can be used across all species, and we just need to get started doing them and get started measuring to find out what's successful. And I talk to my colleagues in the human health sides and hospitals that are trying to do this. So one of the most difficult things to do, and one of the key elements and why it's on top, is leadership. So without leadership, these programs don't work very well, right? And who is the leader? So who's going to be the leader in animal agriculture when you put stewardship forward? I think it's going to be the veterinarians. Right? So I think those are doable, can be done. Whoops. So I think you saw this, and I want to talk just a little bit more about stewardship because Dr. Hicks talked about this. This is getting to be a little bit old now, but somebody referred to it. It's a map of the outpatient antibiotic usage rates by regions of the country. And they just show you this to look at what's happening when you have almost 260 million courses of antibiotics being used a year. And the interesting thing about that is, it's actually looking at the difference between 936 courses of antibiotics per year in the South and 638 in the West and 300 in Sweden. So why is that? So why is there that much difference? So I believe it's about leadership and it's about culture. So I will tell you, and I've been involved with lots of veterinary students over many years, and we're doing a better job of teaching them and talking to them about pharmacology and all of the things. And we really are putting out, I think, really good products, right? And as soon as they get with a senior clinician, or as soon as they get in their first job, and they do things differently, guess what happens? That learning goes out the window, and you get the differences like that because it's embedded in the culture of that practice. And it's pretty hard to go against it. So I show you this with the idea that is something about understanding the culture and the importance of stewardship, but not to underestimate the difficulties, right? And those 260, and those are just outpatients, right? So there's a lot more doses than that given per year. That I was always surprised that dentists are almost 10%. So 26 million doses comes from dentists. Well, I went to the dental school at a university, I could say that, Ohio State, and I'm not there now. And great people, and they had zero program in the use of antibiotics. And we actually brought them into a university committee for the first time. And they're giving out 26 million doses of antibiotics, right? So stewardship works. There's a need for it. And the last thing then about really stewardship that we need to really pay attention to is the barrier of behavior. And people talked about behavior science, they talked about implementation science, but behavior science is really critical to that. And there was a guy by the name of Linder who, can't remember what university, is he at Hopkins? Is he at, I can't remember. Anyway, he's done a lot of work on that. And he says, by the way, in physicians in a busy practice, they aren't thoughtful and logical and taking time, right? That when they prescribe, it's emotional, social, fast, and automatic. And they're on with it. And by the way, when they're under a lot of pressure, and I think Dick said this as well, there's decision fatigue. And if you want an antibiotic, go in later in the day because there's a difference in the rate of prescriptions. It's been proven. It's been, So, and then they have surveys, right? So satisfaction surveys. So how would you like to have a Yelp survey to say, how well did you get, how good was this doc, right? You say, well, he didn't give me my prescriptions of antibiotics. There's a lot of subtle pressure on people, to do this. So there's a bias just to be safe. Just to be safe stuff is no longer the case. The number one cardinal principle, right, in medicine and in veterinary medicine. First, do no harm. First, do no harm. That's not the case anymore on using antibiotics indiscriminately. We already talked about changing the microbiome, adverse reactions, adding to the resistance, right? So there are adverse effects to making the wrong decisions, and I would say to my veterinary students, I hope you practice veterinary medicine ethically, and it's not ethical to use a drug inappropriately when you have adverse effects. Okay? The 800-pound gorilla, the CMS, who will, in the future or starting now, determine what they actually give back to hospitals based on their stewardship program. So if you want an incentive or a disincentive, right, try that. That actually works. So there's other things. On the animal health side, there was a really good study done in the Netherlands, and not that they do it better than us, but they do it differently, and we have things to learn. It was a structured animal health planning program that went 3 years, veterinarian, nutritionists, other people that made group decisions about, including the producer, about the best decisions on those farms. And they had a significant reduction in that amount of time. Evidence-based is important, right? And anybody know what the IKEA principle is? So the IKEA principle is if you order a piece of furniture from IKEA, you don't get the furniture, you get a bunch of boxes. And it's up to you to put it together. So the IKEA principle is, and it's actually true in marketing, right, that people value products that they've created or be a part of. So these top-down approaches have to also have a bottom-up. They need an IKEA effect because you're helped developing those and you have a perspective that's really important when we go forward. There's a cognitive bias and IKEA effect. All right, so stewardship can work. There's evidence that that's done. I won't spend a lot of time on that. Probably the biggest one is peer comparison. So a study done to say you're a top performer if you are actually implementing an effective stewardship program. And by the way, if you aren't, you're in a different category. And you actually mail that out or tell people what category they're in. It is a driver of behavioral change. So benefits, playbooks, and the last one it just came out was a study by Bauer. It was a meta-analysis of 32 large studies that looked at stewardship with a large population and found a 51% reduction in MDR gram-negative pathogens, most effective when combined with infection control plans. It works. We have evidence that it does. We don't need to have a study of 2,000 and 200,001 to move on it. Okay, the second one, awareness. So we had a great conversation about that. In Europe, I think the big driver was this report, right? This caught the attention of a lot of people, but especially funders, and especially health organizations and veterinary organizations. And, you've seen this, and Jim McNeil is an economist, but he has a lot of clout and a lot of credibility. And he says, well, if the status quo continues, we're talking about 10 million deaths a year worldwide just due to infections of resistant organisms that we can't treat. And then he talked about trillions of dollars added into the system, et cetera. So it's those kinds of things then that pay attention. So you have to have this compelling evidence. We need a national leader. And why is it that this messaging, if this is important as what we think it is, this slow burning epidemic that is taking its time, right, but just adding up as we go, to have this a major social issue? Why is it that when we talk to people, they say, this is really a crisis, and I agree that they're over there actually helping get this crisis going, but it's not me. It's the tragedy of the commons. They're not connected with what they do, with I do, right, into this problem. So I think making it, so what happened with HIV? You know, the ban played on. It actually became a social issue that gave a lot of funds, a lot of research, to move it forward. Tobacco. Tobacco is changing right now in terms of marketers going to a millennial generation and less to say, you are the generation that finally can stop the use of tobacco. They made it into a social cause. Now, that's a different strategy, folks, than what we've been talking about. And then who gives the message? Is it somebody else from agriculture? Or is it the head of CDC? Or is it the head of the Public Health Agency? Or is it the head of an economic group that talks about the importance? So the message here is really important. So this has to be personal, it has to be socialized. And we have to quit playing defense. And I think that's really going to be important. Voices beyond just health. And this loss of urgency is the real deal as we move forward. Okay. So in terms of communication, right, so this is the UK 5-year antimicrobial resistance strategy. Okay, it's still underway, but I want you to note who signed it. So this is a national strategy going out to the countries in the United Kingdom, and it's signed by the Chief Medical Officer and the Chief Veterinary Officer. Now that is an awareness and a signal in communications that's really important. So while we talk about having great collaboration in the public health side, and it certainly is getting better, and I couldn't be more pleased. This was the starting point. And what a different kind of strategy to think we're not just going to talk about doing this, we're actually going to do it and put our signatures for, so it's part of that. Infection prevention. Not going to spend a lot of time on it. You're already doing it. But I think having a decision about what works, what doesn't work, and what can be specific to certain species is really important. Sanitation and hygiene, it's biosecurity, and these health management strategies are the benefits of a veterinary feed directive. It's being on the farm not just to advise about an antibiotic, it's to be on the farm together to put a strategy together to prevent an infection in the first place. And how important that is when combined with stewardship. Improving the host immunity, conceptualizing bacteria was really talking about the microbiome, environmental risk reductions. So it may be that antibiotics in the environment are an environmental contamination, that we might see different policy change. Build on existing practices. This is not something new. It's accelerating and doing it where we can prove that it works. Effective vaccine is a key part of that strategy, and new vaccines coming forward. It's more than just reducing antibiotic use, but it's also cost savings. People tell me how much it's going to cost them by not using antibiotics. I thought also antibiotics was a cost. So I think we need to think about that as well as we move forward. Okay, what about this institute? So the institute idea came from actually two sources. The first one was the PACCAR, the President's Advisory Council on Combating Antimicrobial Resistant Bacteria. Just came out in September. It's a public document, so I'm allowed to talk about it. And Peter Davies is allowed to talk about it. It's about creating and funding an institute. In this case, they recommended in USDA, but I'm not hung up about where it should be, to support research across species with an emphasis on immunology and vaccine development, assist in education at various levels, provide for key field studies to conduct, evaluate, and create a database of efficiency studies on alternative antibiotic products. Wow. Wow. Can we do that? Absolutely. And that institute could be started really quickly. We don't need to wait to $100 million and go around the country and decide how we're going to do this again. All right? Action can be taken right now. Okay? And when the AAVMC and APLU got together in their task force, one of their key recommendations was creating a university-based research organization and coordinate the research, education, outreach programs to address AMR recommendations from that task force. Exact same idea. Maybe a different place to put it. It's not important. It's the exact same idea. So here are two groups, very influential, talking about the same thing and the need to get that done. They emphasize public-private partnerships, $455 million on CARB-X. Really? Public-private partnership, right? Coordination interprofessionally in One Health is the foundation. Can be done, should be done. Doesn't have to wait till next year to decide that this is an appropriate action. So I think we need this national focus, and on leadership, it's a critical issue. We need to make sure, because we don't have a big pot of money, that we avoid duplication. And we need this One Health Foundation and this public-private partnerships. I'm going to move it along. Changing the business model. Okay? That's the last thing. So it's push incentives for sure. And we do a pretty good job in that, because that's really about research as we go forward. But it's these pull incentives. The idea of innovative new strategies for companies to say, yes, we're in the business now of producing new antibiotics. And that may be market rewards, it could be new entry models, insurance models, different revenues, but the decision can be made quickly, why the action takes a long time to go. So let's move on through there. So this is just my, my chart. Say, okay, let's compare actions, and let's look at the criteria. And this is just the way I have looked at this, to look at timeline, cost, scalability, evidence-based impact, and barriers. And are these made? I'm happy to make these slides available if people ever want to see them. But it gives you some idea of the structure to make a decision and why you can do that on these 5, right? Tier 2, R&D. Doesn't mean R&D is less important than stewardship. It just means that you have so much money to spend, and this is going to be more midterm. Alternatives to the antibiotics, right? Host response, horizontal transmission, One Health surveillance, absolutely. Field studies to measure effectiveness. I'm going to spend a lot of time on these. I'm going to end up on research and expanding fundamental relevant research to develop new antibiotics, alternatives to antibiotics, improve our fundamental understanding of AMR, the need for looking at study designs and the measurement, testing, stewardship, and infection prevention, and then these studies down the road on microbiome. Need for research in the social and behavioral sciences, you've heard that. Studies about the proof of concept of these ideas as we move forward. The last is these are tier 3, just as important, but longer term. Kind of the global integration. Yes, basic research takes time, but important for sure. And new antibiotics may take 10 years from the start all the way through the approval process. Let me just end with this. So I believe in a guy named John Cotter. John Cotter comes out of Harvard, and I don't believe in him because he came out of Harvard, just because he's done a lot of research and he's really evidence-based, right? And he did a study on a couple hundred major corporations who were going through major changes, transformations. And he wrote this article, he actually wrote a book about it, and he said, these are the 7 barriers. If you overcome them, right, you actually greatly increase your possibility of success. And we need to think about that in this strategy moving forward. Create a real sense of urgency, right? I'm worried that we're actually losing that. Create a powerful enough guiding coalition. Oh, so what's the guiding coalition? Well, now we know it's public health and animal health. Now it's environmental health. What are the other factors and groups that aren't in here to be part of that guiding coalition? Who's been left out? Who do we need to have? Establishing a clear and compelling vision. So what is the vision? Is it about no use, less use, resistance, or is it about optimizing health, right, through judicious use? And then communicating that vision. And he believes that we under-communicate tenfold. Under-communicate tenfold. And then he said, removing obstacles and empowering others. So I gave you a list of obstacles, not because I think that we should get tied up in it and can't do them. I give them to you because they're barriers that we need to knock over. Planning and achieving short-term wins. Well, I think the response to guidance from FDA was a huge win that not enough people know about. Okay. Not declaring victory too soon, and then anchoring change in organizational culture. When you get into the cowboy in the pen, separating healthy animals from not, and he said, this is the way that we do things around here, you've made it. So you have to embed it in the culture. I'm stopping there. I hope you can ponder these kind of 5 actions we can take before we meet each other again in a year. Here's the evidence of why we can do it. Here's the cost that we just gave you a little bit of dollars to do it. And I think all these are doable, and they'll make a huge difference in our progress going forward. Thank you very much.
Dr. King, thank you.